بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على رسول الله نبينا محمد وعلى آله وصحبه أجمعين. I am Mohamed Bahashwan from Group 5. Welcome to our seminar, Peptic Ulcer Disease. The case is 45 years old male patient complained for the last 15 years of pain, epigastric with heart pain which was related to hunger. He was diagnosed as peptic ulcer and needed treatment. 12 hours ago, he felt sudden severe pain in the epigastrium with severe vomiting. On clinical examination, inspection, the patient was still lying with leg of the abdominal movement during respiration. The respiration was rapid and sharp. General examination, pulse 100 beats per minute, blood pressure 100/75, temperature 38 degrees. Palpation, vegetative abdomen with rebound tenderness. Auscultation, no intestinal sound. Blood examination, normal serum amylase. Leukocyte count 13,000. Plain X-ray chest, rivers, free gas under the diaphragm. The patient was diagnosed to have a perforated peptic ulcer with erythemas. زيادة على الفعل.
زيادة على
الفعل.
جروب كام بقى؟
جروب
انتوا مختلفين ولا كلكم جروب واحد؟ مختلفين. طب كل واحد يطلع يقول الجروب بتاعه بعدين.
What is the stomach? What does the stomach look like? The stomach is a muscular sac and it's like a G shape. And the stomach occupies the upper left quadrant of epigastric and the umbilical region, and much of it lie under the rib. And we divide the stomach to 4 regions: the cardiac region, the fundus region, and the body, and the pyloric. The cardiac region, which is surrounded by the opening of esophagus, and the cardiac region and the fundus region, which is the area above the level of cardiac orifice, and the body region, which is the largest region in the stomach, and the pyloric divided in pyloric canal and pyloric atrium. And the stomach has 2 openings: gastroesophageal opening and pyloric opening. And also the stomach has 2 sphincters, the cardiac sphincter and the pyloric sphincter. And other features of the stomach include the greater curvature and lesser curvature. And also the stomach has 2 notches, the cardiac notch and incisora angularis notch. And the stomach has 2 surfaces: anterior-superior surface and inferior and posterior-inferior surface. The stomach anatomical relation in the anterior-superior surface in the relation with the diaphragm, the liver, and the anterior abdominal wall. And in the posterior-inferior surface in relation with the diaphragm and spleen and the left kidney and the left suprarenal gland and the anterior surface of pancreas and the left colic flexure and the transverse mesocolon and the splenic artery. And the stomach separated by its bed and the stomach separated from its bed by the lesser sac. The blood supply, the stomach blood supply. The arterial blood supply of the stomach is the left gastric artery and splenic artery and hepatic artery. The left gastric artery will supply the cardia of the stomach and the distal part of esophagus. And the splenic artery will rise to short gastric and left gastroepiploid. And it will supply the greater curvature. And the hepatic artery will give rise to the right gastric and the gastroduodenal artery. And the right gastric will supply the portion of the lesser curvature. And the gastroduodenal artery will give rise to superior pancreaticoduodenal and the right gastric and the right gastroepiploid. the stomach innervation. The main stomach innervation, the main innervation of the stomach is the left and right vagus nerve. And the parasympathetic innervation of the stomach is the vagus nerve and the pterygium nerve. And the sympathetic innervation of the stomach is splenic nerve.
I'm Hamza Ahmed Al-Kharoubi, Group 2. Hamza Ahmed Al-Kharoubi, Group 2. I will discuss with you some information about the duodenum. The duodenum is C-shaped tube. It's nearly 10 inch in length. We will focus on the first part of the duodenum only. It's nearly 2 inch in length. As you see, the first part of the duodenum runs upward and backward on the transpyloric plane at the level of the first lumbar vertebra. Relation. The anterior relation of the first part of the duodenum is quadrate loop of the liver, and as you see, gallbladder. On the posterior of the first part of the duodenum, we will find bile duct on the right side and gastroduodenal artery on the left side. Posterior of them, we will find portal vein. Most posterior, we will see inferior vena cava. And the lesser sac, it will present the posterior relation for only first inch of the first part of the duodenum. Blood supply. The upper half of the duodenum artery of the duodenum is supplied by pancreaticoduodenal artery, which is branched from gastroduodenal artery. Nerve supply. The duodenum is supplied by sympathetic and vagus nerve via the celiac nerve and the superior mesenteric plexus. Thank you.
Group 3. Hamza Hassan Bayan, Group 3. Are we talking about broad stomach dilation or functional stomach dilation? Stomach or stomach food and regulation of spaghetti to small intestine. Stomach makes saliva, food, and gastric juice to form sac. Gastric is a hormone that tells stomach to start release gastric juice. Endocrine function secrete gastrin releasing peptide, vasoactive intestinal peptide. Secrete gastric juice. Gastric juice secrete from beta cell and chief cell. Beta cell secrete H cell and tryptic factor. H cell kill bacteria, activation of pepsin gene to form pepsin, maintain pH in the stomach, convert iron from ferric to ferrous. This factor helps for absorption of vitamin B12. Chief cell secrete pepsinogen and gastric ligands. Pepsinogen activation by HCl to form pepsin. Pepsin ligation of protein. Gastric ligand ligation of short, medium, and unsaturated fatty acid into free fatty acid and glycerol. Gastric ligand is important for digestion many fat in everything.
Assalamu alaikum. My name is Aziz Ibrahim Barman from Group 2. We will discuss about the mechanism of SCS secretion by stomach. Before we start, we will talk about the parietal cell. The parietal cells, also known as oxyntic cells or polymorphous cells. These are epithelial cells that are found in the fundus and body of the stomach, but the main secretion of HCl from the fundus. As you see, the shape of parietal cells is a pyramidal in shape. As you see, the shape of parietal cells is a pyramidal in shape with the apical membrane invaginated to form an intracellular canalicular system. From this system, the secretion of HCl. This cell compresses about 80% of the stomach. We have some factors which stimulate the secretion of HCl. The first one is the histamine and acetylcholine and gastrin. The histamine is a chemical substance that is produced from the ECL cells, which is called enterochromaffin-like cells in the lamina propria. This histamine will combine with the H2 receptor on the surface of parietal cells to stimulate the secretion of HCl. Also, we have acetylcholine. The acetylcholine is a neurotransmitter will produce from the vagus nerve ending and combined with the M3 receptor on the surface of parietal cell to stimulate the HCl secretion. We have also the gastrin. The gastrin is the hormone produced from the G cells in the biliary antrum and upper intestine. This hormone will combine with the G receptor on the surface of parietal cells to stimulate the secretion of HCl. These factors will directly and indirectly stimulate the secretion of parietal cell. The direct pathway, this factor will stimulate the parietal cells by exchange of potassium with the hydrogen to the lumen by hydrogen-potassium ATPase. An indirect pathway, the acetylcholine and gastrin will stimulate the ECL cells to produce the histamine, and the histamine will stimulate the parietal cell. We have also psychic stimulation. When you're seeing or smelling or even thinking of the food, which is called the conditional reflex, the efferent impulses will go to the vagal nucleus in the medulla oblongata, and these impulses will be carried by the vagus nerve. When the vagus nerve reaches the stomach, it will release the acetylcholine, and acetylcholine will stimulate the parietal cell. Also, the vagus nerve will go to the biliary antrum and stimulate the gastrin-releasing peptide. And the gastrin-releasing peptide will stimulate the G cells to produce the gastrin. And the gastrin will transport in the blood to stimulate the parietal cell. We have stimulation of HCl secretion by emotions like anger and aggression and mental stress. These factors stimulate the HCl secretion, but fear and depression will inhibit the HCl secretion. We have also mechanical stimulation. The parasympathetic stimulation by releasing of acetylcholine, which is called the vagal reflex. Also, we have nervous plexus. These receptors are very sensitive to the distending of the stomach, and it will send the afferent impulses to the neurons in the nervous plexus of the gastric wall, and these plexus will send the efferent impulses to stimulate the gland cells by releasing of acetylcholine and gastrin.
طارق عادي كتب جروب 2 طارق عادي كتب from group 2. What is the cellular mechanism of HCl secretion in the parietal cell? In the parietal cell, the carbonic anhydrase converts the water. In the parietal cell, the carbonic anhydrase converts the water and carbon dioxide to carbonic acid, and the carbonic acid dissociates to hydrogen ion and bicarbonate. The hydrogen ion exchange with the potassium by hydrogen-potassium ATPase, and also sodium exchange with the potassium by sodium-potassium bond, and the potassium diffuse into the lumen. After that, the bicarbonate exchange with the chloride ion, and the chloride ion diffuse into the lumen for combine with the hydrogen ion to formation of HCl.
السلام عليكم ورحمة الله وبركاته. I'm علي أبو زين from Group 5.
علي أبو زين Group 5. What is the peptic ulcer? The peptic ulcer is discontinuation or breaking of the gastrointestinal mucosa. And what is the most common site that occur peptic ulcer? The first common site if the ulcer occur in the duodenum, which is the first part of the small intestine, and this ulcer called duodenal ulcer. And the second most site, the ulcer occur in the stomach near to the nasal curvature due to passes of the food there, and this ulcer called gastric ulcer. And the third most part
if the ulcer occurs in the lower part of the esophagus due to any defect in the lower esophageal sphincter. And this ulcer called esophageal ulcer. The fourth site, the ulcer occurs in the jejunum, which is the abnormal site. It's occurring in the jejunum, the abnormal site, like here, as you see. And if there are multiple ulcers occur in the multiple sites, as occur in the lower part of the esophagus, and the gastric, and in the jejunum, also occur in the abnormal site in the jejunum. This indicates for the disease called Zollinger-Ellison syndrome.
أكرم محمد الرزاق from group 3. أكرم محمد الرزاق. Cause peptic ulcer. Hypersecretion of gastric juice, distribution in mucosal bicarbonate and distribution in epithelial repair. Mucosal bicarbonate barrier consisting of epithelial cells, lamina propria and muscularis mucosa. Protect the stomach from the harmful effect of HCl. This barrier can be opened by many factors that cause gastric irritation, including ethanol, vinegars, bile salt, aspirin, non-steroidal anti-inflammatory drugs, and antiprostaglandin. Therefore, these factors can predispose peptic ulceration. There is balance between range of secretion of gastric juice and degree of protection. Factors that cause imbalance between them are increase in the secretion of acid and pepsin by gastric mucosa, decrease in the ability of gastroduodenal mucosal barrier to protect against the acid pepsin secretion, and decrease in the neutralization of gastric acid by duodenal juice. Specific cause of peptic ulcer. Many peptic ulcer patients have been found to have chronic infection of the terminal portion of the gastric mucosa and initial portion of the duodenal mucosa. Infection most often caused by the bacterium Helicobacter pylori. The bacterium is capable of penetrating the mucosal barrier and lead to peptic ulceration. Tests performed to confirm Helicobacter pylori infection. Blood antibody test, urea breath test, stool antigen test, and stomach biopsy. Other cause of peptic ulcer: smoking, possible because of the increased nervous stimulation of the stomach secretory gland, and alcohol because it tends to break down the mucosal barrier. Thanks for.
السلام عليكم. أيمن الخطاب ثلاثة.
كم؟
ثلاثة. 3
3
Initiate the anti-inflammatory drugs that class of holistic medication that reduce inflammation of the brain and the liver. Most common type of these drugs: ibuprofen and naproxen and aspirin. Side effect of these drugs: stomach pain and stomach ulcer and gastritis. Gastritis means inflammation of the stomach lining or bleeding now or in the muscle. And diarrhea and heartburn and increased blood pressure. Mechanism of ulceration due to insect usage. The mechanism of these drugs, they are due to their binding ability to the active site of cyclooxygenase and inhibited this catalysis of articulate acid to prostaglandin. Traditional insect considered as non-selective because inhibited both COX-1 and COX-2. Site of inhibitor of prostaglandin synthesis. Phospholipid conversion to articulate acid catalyzed by phospholipase A2 inhibited by anti-inflammatory steroid drug, and articulate acid conversion to prostaglandin catalyzed by cyclooxygenase and inhibited by NSAID. Prostaglandin will provide inflammation and pain and protect gastric mucosa and support renal and bloodless function. Instead, decreased prostaglandin will lead to increased mucosal secretion, increased HCl,
finally inflammation of the GIT fragments. Thank you.
معلش انا رجعها تاني معلش اخيرا.
بعدها اللي قبلها
محمد محمد بهشوان جروب 5.
The location of the ulcer in the previous patient. As I said in the history of our patient, that the pain was related to hunger. This pain, which is related to hunger, is an indicator to the duodenal ulcer. But if the pain was coming after eating or related to eating, this indicates the gastric ulcer. So the location of the ulcer in the previous patient is the superior lateral wall of the first inch of the first part of the duodenum. And this site is the most common site of the duodenal ulcer. Why this site is the most common site of the duodenal ulcer? Because the acidic chyme which is coming from the stomach beat the duodenal mucosa before mixing with the alkaline secretion. And also the gush of the acidic chyme hit the superior lateral wall first.
خالد الأحمدي جروب 2.
مين؟
خالد الأحمدي group 2. Now the mucus layer disappeared and the ulcer has developed in the wall of the gastrointestinal tract. So by the time acid secretion will cause more damage to the wall till it perforates the wall and make a hole. According to the size of this hole and its complication, we have two types of peptic ulcer: perforating ulcer and penetrating ulcer. Perforating ulcer is a hole in the anterior wall, and perforating ulcer there is a leakage of contents into peritoneal cavity, which causes peritonitis. Penetrating ulcer is a hole in the posterior wall, and in this ulcer the damage will continue to adjacent relations of the ulcer sites. The ulcer site just as an organ or structure. Penetrating ulcer in the stomach will lead to will penetrate the splenic artery, which will lead to accumulation of blood in the lumen of the stomach, and that causes hematemesis, vomiting of blood, or it damages the pancreas, which causes pancreatitis. Penetrating ulcer in the duodenum or in first part of the duodenum will penetrate the gastroduodenal artery, which also will lead to accumulation of blood into the lumen of the duodenum, and that will lead to hematemesis and melena. Melena is digestive blood in the stool. It is dark blood because of the reaction between HCl and hemoglobin, which form hematine acid, which gives the blood its dark color. Thank you.
Assalamu alaikum. Hisham Kadib from Group 5. Hisham Kadib.
Air under diaphragm. As Khalid said, there are two acute presentations of duodenal ulcer: anterior duodenal perforating ulcer and posterior duodenal penetrating ulcer. Posterior duodenal penetrating ulcer causes acute abdominal pain and internal hemorrhage that manifests as upper GI hemorrhage and vomiting of blood, which is called hematemesis, and lower GI hemorrhage and passing tarry black stool, which is called melena. And we have to know that hematemesis and melena are caused by rupture of gastroduodenal artery, which is made posterior to the duodenum. Anterior duodenal perforating ulcer causes air to leak from the duodenum and accumulated under the right hemidiaphragm, and making a diagnostic radiologic sign called air under diaphragm which is characteristic for perforated of hollow viscous. Let's see some X-rays. In this X-ray, there are no air accumulated under the right hemidiaphragm, so this is normal. This X-ray shows us air accumulated under the right hemidiaphragm, and this indicates that this patient has anterior duodenal perforating ulcer. But this air is in the fundus of the stomach, which is physiologic sign, not pathologic. And this presentation will be acute abdominal pain and shock.
What is the peritoneum? Peritoneum is a continuous thin sheet of tissue or membrane that's lined the cavity of the abdomen and the belly and cover the organ found within. And it consists of two layers, parietal layer and visceral layer. Parietal layer is the part that lining the cavity of the abdomen, and the visceral layer is the part that covers the organ found in the pelvic and the abdomen cavity. Nerve supply of parietal peritoneum. Parietal peritoneum is sensitive to the pain and temperature, so it's supplied by somatic nervous system, and it divides the peritoneum into three parts. The central part of the diaphragm supplied by the phrenic nerve, and the peripheral part of the diaphragm supplied by the lower 6 intercostal nerve, and the anterior abdominal wall supplied by the lower 6 intercostal nerve and the first lumbar nerve, and the pelvic wall supplied by the obturator nerve. The effect pain of the parietal peritoneum, the phrenic nerve will refer to the tip of the shoulder, and the obturator nerve refer to the inner side of the thigh. The nerve supply of visceral peritoneum. Visceral peritoneum is not sensitive to the pain; it's only sensitive to the stretch, and it's supplied by the autonomic nervous system. The perforating peptic ulcer will lead to epigastric pain and peritonitis. The epigastric pain because the pain in the stomach and duodenum will carry out by the sympathetic nerve to spinal cord at segment T5 to T9 and give rise to a referred pain in the skin supplied by the same segment. And the peritonitis is the inflammation of the peritoneum. The peritonitis will lead to a fever. As we see in the scenario, the elevation of the temperature will lead to a tachycardia, and the vomiting will lead to a minor decrease in the blood pressure. And the rigidity or the rebound tenderness, it's the reason why it's the main reason why there is no intestinal sound, and increase in the number of the leukocytes. The rigidity or the rebound tenderness and the severe pain is the main indicator of the peritonitis.
رأس على جمالي ركبته.
So, as you know, the peptic ulcer gives pain in the epigastrium. But that doesn't mean any pain in the epigastrium. It's only due to peptic ulcer. Because there are other organs and other diseases that give pain in the same region. Like in the pancreas, we have pancreatitis, which is inflammation in the pancreas. And in heart, we have inferior myocardial infarction. Then we have appendicitis, which is inflammation in the appendix. The fourth disease in the gallbladder, we have two diseases. The first one is cholecystitis, which is inflammation in the gallbladder. And the second disease, as we see in the picture, this is the gallbladder, and this is the stone inside the gallbladder. This disease called gallstone. Then the patient who has cancer in the stomach, his pain may be referred into the gastric region. In the esophagus, as you see in the picture, this picture gives you the esophagus very clearly, but the patient who has esophageal cancer, his pain also referred into the same region, which is the gastric region. Finally, I have hepatitis, which is inflammation in the liver. So all these diseases refer pain into the same region. Remember, there are many regions give pain in the same region, which is the gastric. So this point is very important, especially in the clinical part. If you want to make a perfect diagnosis, We should know about all these diseases. Thank you.
The last point of our seminar is the management of the peptic ulcer.
The management of the peptic ulcer depends on the cause of the peptic ulcer. If the cause is the hypersecretion of HCl, we have two procedures. Neutralization of HCl by antacid or block the receptor that stimulates secretion of HCl. H2 receptor blocked by cimetidine, famotidine, ranitidine, nizatidine. And muscarinic receptor blocked by atropine and benzimine. Hydrogen potassium pump blocked by omeprazole. And the patient with an infection of Helicobacter pylori, just we give him antibiotic to kill the bacteria. The surgical treatment. You may need surgical treatment if there is ulcer perforating wall, bleeding ulcer, ulcer returns, ulcer block, stomach exit. Vagotomies cut the two vagus nerves that supply the parasympathetic stimulation to the gastric gland to reduce acid secretion in the stomach. And gastrectomy, two types, partial and total. Partial again, two types, enterectomy and biliroplasty. Total gastrectomy, we use it if there is cancer of his perforating case. There is other useful substance that use in management of the peptic ulcer, such as sucral fat, which increase the resistance of the mucosal barrier in the stomach. Finally, thank you for your attention. Assalamu alaikum.